Is pain inevitable during childbirth? If pain is an output of the brain, are there ways to educate our pregnant clients to help minimize their pain perception during delivery? Listen to today's episode to hear Carolyn Vandyken, a Canadian physiotherapist, as she explains how using pain science is a better way to support our pregnant clients.
Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Hello, everybody, and welcome to this amazing episode where we are going to be talking about, is pain in childbirth inevitable? And I would like to welcome to this episode Carolyn Vandyken. Carolyn is a physiotherapist up in Canada, and she is co-owner of Reframe Rehab, an educational platform. And Carolyn has spent her 35 years of clinical practice trying to break down the silos between pelvic health, orthopedics, and pain science. And she's done a lot of research and writing around that and is educating all of us as well. Welcome to the Birth Healing Summit podcast, Carolyn. Thanks for being here.
Thanks, Lynn. Thanks for inviting me. I really appreciate the invitation, and I'm excited to dive into this topic.
Yeah, so I have to say, pain science in me, I'm a little like, So we're gonna have a really good conversation here today, because we're gonna be talking about, is pain in childbirth inevitable? So what do you mean by that, Carolyn? I mean, in our culture, our society, everyone's like, childbirth equals pain.
Right. Absolutely. And so it's a cultural expectation, isn't it? And yet we
Yes.
know in other cultures, we know that even within our cultures, some women have a lot of pain in childbirth, and some women have very little to no pain in childbirth. And so, how can the same event create a very different experience for women, right?
Yeah.
And that's women within a culture, but also between cultures. So it's very, very interesting, right? And so we have this cultural belief. If you ask a woman, hey, how was your childbirth? She'll say things like, oh, it was bad. I had a lot of pain. I had a lot of back pain. It was really terrible, right?
Yeah.
Or you might ask another woman, hey, how did it go? And she'll say, you know what? It actually went really well. I had very little pain. I was able to stay on top of things. And so we almost define the success of our childbirth based on the amount of pain that we experience. But
Yeah.
one of the things that most of us don't recognize is that pain is actually produced by our brains. Pain is not produced by our tissues. And so the same tissue event, right, the contracting of the uterus and the opening of the birth canal and the descent of the baby through the birth canal and out the vagina, that same sort of tissue event creates a very different experience for every single woman.
Mm-hmm. Have you heard of orgasmic birth?
I have actually, but I don't
Right.
know. I've done a lot of reading on it, but
No, but just that concept that birth
yeah.
can be orgasmic, I think is kind of like mind blowing for most people.
Right.
And so I think it goes to your point that it's all the perception of the brain and how you're choosing to look at it. Is that what we're
Mm.
talking about, Carolyn?
So it's very complex. Pain is always a complex situation. So it's never just a simple story, right? And
Yeah.
part of it will start with, what are your own sort of expectations around childbirth, right? What have you been told? How many stories have you heard? Did your mom and your aunts, sort of tell you about very difficult childbirths, or did they kind of say, hey, things went really well? What has your experience of pain been like? Have you struggled with persistent pain? Have you had painful episodes? What do you know about pain? All of these things, sort of create our pain experience, right? And so one of the things we need to understand is that basically pain is produced by our central nervous system, our brain. And that doesn't mean it's in your head, because that's a real misnomer, right? So sometimes people
Yes.
think, well, so what you're telling me is that I create my pain, or pain is in my head. And what your brain does is produce pain to protect you. That is absolutely the underlying purpose of pain, right?
Yeah.
And in childbirth, kind of like in running a marathon, what is pain protecting you from, right? There's no tissue injury in the process of labor. Now, in the process of delivery, as things stretch, it depends on the size of the baby and your own pelvic sort of, outlet and inlet, and lots of different things happening there. Structurally can make a difference for sure. But like running a marathon, you are probably going to have some pain in that experience. Running a marathon is an intense experience. Having a child is a very intense experience as well, right? But
Yeah.
it doesn't have to be painful. And when there is pain, it's not because you've injured tissues, which is normally what we think about pain. When we have pain, I've injured something. I need to pay attention and do something about that, right?
Yeah.
So childbirth pain is different that way.
Okay, so Carolyn, I've done both. I've had a vaginal
Hmm.
birth and
Okay.
unmedicated vaginal birth. And I've
Yeah.
also only trained for a half marathon, but ran the full marathon. So I decided going to the start line, I'm never going to train for a full marathon. So I'm going to run the whole thing, and just not train for it. And it was very interesting as I was experiencing it mile after mile. I would occasionally get knee pain, and I would
Mm,
just keep running, and I just observed it. It
mm,
was almost like I didn't give it that much weight, or I
mhm,
didn't freak out about it. I was
mhm.
curious because, like, well, gosh, I still have 12, 14, however many more miles to go, and I'm
Right.
getting this knee pain. But then what I noticed is that then it shifted to a foot pain, then the other foot pain, and it just kind of shifted and changed, but I didn't freak out about it.
Mm.
Okay, now,
And that was probably the key, right, Lynn? Is
yeah,
is again what we know. So when we have an acute problem, so if I cut my finger tonight while I'm prepping supper, I'm cutting up my vegetables for dinner, right? And I cut my finger. I stop immediately. I see the blood. I stop what I'm doing. I go to the sink. I rinse the cut. I stop the bleeding. I assess the damage. I decide, okay, I don't need to go to Emerge. That's great because in my small town of Huntsville of 20,000, there's no after hours clinic. I'm heading to Emerge for a 4 to 6 hour wait to get some
yeah,
stitches. So I'm thinking, okay, that's not happening.
yeah,
That's great. I put a bandage around it and it throbs, right?
yeah,
And I go back and I finish cutting my vegetables and I'm kind of cursing under my breath, thinking, how could I be so careless and silly me and whatever. But then I kind of don't give it more thought, right? And by bedtime tonight, maybe around 11 p.m., I see the bandage on my finger and I go, oh yeah, I cut my finger. Oh, interesting. I wonder what it looks like. Did I make the right decision not getting stitches? So I very carefully peel the bandage away. And the cut is as cut as it was 6 hours before that,
hmm,
right? But I don't have pain anymore. Now, if we always equate pain with tissue injury, which in our culture we do, right? So if I have pain, there must be something wrong. When you were running your marathon, right? What happened was you're getting knee pain. And so as a physio and kind of understanding physiology, you're like, yeah, I know I'm getting tired. There's fatigue going on.
yeah,
I'm straining a system. It's becoming sensitive. But I haven't damaged anything. Nothing's injured at this point. I'm running a marathon. And not only did I decide to run a half marathon, I decided, what the heck, let's go for a full marathon, right?
right,
And so, there was definitely danger signals coming from your knees, danger signals coming from your feet. When I cut my finger, there was danger signals coming from my
yeah,
finger. And I got pain because my brain said, hey, Carolyn, you need to do something about that. Check it out. And so I did. Okay, I cleaned it, so I'm not going to get infected. I don't need stitches. And I put a bandage on it. So I did all the right things that you need to do for a cut. And within 6 to 8 hours, there's no more pain, right? And
right,
even when I peel the bandage away, the cut is there, there's no pain. And the reason for that is because my brain now knows that I've done all the right things and my brain is not worried about it. And my body goes around about healing that tissue. And as long as I'm not silly enough to keep sort of nicking the cut as it's healing, I don't feel anything in that cut anymore.
yeah,
Right. And so that's an example I will often use with my patients to get them to start thinking about pain as an output. Pain is your brain's way of getting your attention.
Mhm.
Now, when we have pain, what the research shows really clearly is even in acute pain, when there's a lot of emotional distress associated with that. Now, first of all, no blame, no shame here, because the definition of pain is an unpleasant, duh,
Yeah.
sensory and emotional experience. So it's not a sensory or emotional experience, it's a sensory and emotional experience. Pain is always both. And when we injure ourselves, it's quite normal for us to freak out a little bit, right? Like, I don't have time for the sprained ankle. I don't have time for my fractured femur. I don't, right?
Yeah.
How am I going to go on vacation next week? That's all been paid for, whatever. There's lots of reasons why we can get distressed about our pain experience. But when we get distressed and we stay distressed, it's actually our pain experience is the other parts of the brain that are lighting up at the same time as maybe the parts of our brain that control sensation and movement in the injured part is our limbic system. And our limbic system is our intense emotional center. And when acute pain is mapped, and that just means if we did a special MRI called a functional MRI of someone's brain when they're in acute pain, if their limbic system is firing strong, they're having a strong emotional reaction to it, the likelihood of them persisting in pain, having persistent pain, is significantly increased compared to if just their sensory motor areas are lighting up.
Ah,
Okay.
yeah.
So it's the distress piece. So, how do we translate that to childbirth? Well, if we're really fearful of childbirth, right? And there may be good reasons. Maybe we've been given lots of stories. Maybe we have some strong beliefs that, my body can't do this or whatever. If we're really fearful of childbirth, if we're catastrophizing, now that's a word that some people will find a little bit maybe offensive even sometimes because it has a suggestion that you're making too big a deal of something. But I want to kind of normalize catastrophization, right? We all catastrophize when something goes wrong for a short period of time, right? Because the research shows that that's what actually gets us social assistance. People around us come and say, hey, it's okay. We're going to figure this out. No problem, right? So
Yeah.
catastrophization helps us to problem solve. So short periods of catastrophization actually really helpful. When we stay in that mode, super not helpful for more sensitivity in your nervous system, a quicker pain response, more protection, right? And
Mhm.
so when women kind of get stuck in this catastrophizing mode around childbirth, like this is the worst thing that could happen. I'm not sure I can cope with it, right? This real dread. Oh, I know I got to do this, but and again, normal, right? And very fearful. And then the other group that really would benefit from understanding more about pain and the pain system is trauma survivors,
Ah,
right? And really looking at sort of adverse childhood experiences specifically. And there's some research that connects that when women address that piece in pregnancy, there's better connections with their baby. There's a better birthing process. And so if pain is an output of the brain and childbirth is an intense experience, we can change that experience by creating more safety
mhm.
in pregnancy, right? More and less danger. And we can do that by getting some counseling for those traumas that maybe are unresolved. We can do that through different techniques like, different breathing techniques and different safety and sort of knowledge education is a safety mechanism, right? And I think we can dive into that in the summit a little bit more.
Okay.
But that's kind of, sort of prepares the way why pain education, not for everybody, but for people who are struggling with high fear, some
Mhm.
catastrophization, which again is normal, and perhaps some adverse childhood experiences or trauma.
Yeah. Well, I know in my practice, I see that whatever isn't fully resolved in their childhood or other events in their life, it gets recreated in that birth experience.
Hmm.
And
Hmm. Yeah,
so it's so important for us to help our clients to try to do their work the best they can prior to that labor experience. So
right, right.
yeah. Um, Carolyn, in my work, and you're talking about this catastrophization. I can't even say the word. That's a big word.
It's a funny word. It's a big word. It's a
Yeah.
funny word. It's kind of think of it like worst case scenario thinking. If you have the tendency to kind of get into this worst case scenario thinking when something happens, that's catastrophization.
Well, I'm curious because what I find in my clients who have experienced a trauma of some sort, and birth trauma being the most that I work with,
Hmm.
I find that there comes a point in that process where they feel like either baby's gonna die or they're gonna die.
Mm-hmm.
And that, it's because it's over the tense. We know trauma is something that someone can't, it's overwhelming to the system,
Right.
right? So
Hmm.
how is that the catastrophization? Do you know what I mean? Like,
Yeah, so that's one form of catastrophization, is sort of worst case scenario thinking, right? Like, I'm going to die in childbirth, my baby's going to die in childbirth.
yeah.
That's one manifestation of catastrophization. Or, you know what, the pain is going to be so intense, I'm just not going to be able to cope with it.
Okay, but that's preparing ahead of time. That's the thought process prior to the actual event.
Right, right.
But that can also actually happen in the moment
Mm-hmm.
when
Mm-hmm.
someone is experiencing, and
Mm-hmm.
we all know the doctors go, if you don't get this baby out, you're gonna have to C-section or
Mm-hmm.
baby selling. And as soon as they
Right,
get that word or the beeps on the monitors change, and then
right.
panic in the room,
Yeah.
that client goes into this like freeze response, that trauma
Mm-hmm.
response of, oh my God, my baby is dying or
Mm-hmm.
is gonna die, or maybe even to the point where the baby died. And that
Mm-hmm.
is what I find being held in the body and in the
Mm-hmm.
tissues. And I think that's what creates more of that pain cycle, um,
Mm-hmm. Mm-hmm.
and
Mm-hmm.
keeps that locked in the body. And so
So yeah, so our intense emotions, right? And that would be a very sort of intense experience, and
extreme.
a fearful, like not just an intense physical experience, but an intense emotional experience, right? And
Yeah.
again, where we get into trouble with trauma is when we don't develop the language around it. So your brain's first job is to create safety,
Yes.
right? And
Yeah.
if it can't create safety in the moment, then it goes into this fight, flight, freeze kind of response. And then your memories become fragmented often. And
Yeah.
because then people can't put the story together afterwards, they
Mhm.
keep reliving and rehashing that traumatic experience.
Yeah.
And those are folks who, again, in a trauma informed lens, we need to help them to connect the dots, see that that is contributing to their sensitivity and their pain, maybe postpartum, right?
Yes.
And then help them to navigate towards a psychotherapist, a social worker, a psychologist who treats trauma,
Yeah.
right? And,
Yeah.
and birth trauma is a very real form of trauma for some
Right.
women. And,
Right.
again, it needs to be addressed. They need to develop language around that. And that's a skilled, a skilled piece that we can't provide as physiotherapists. We can have a lens on it, but we
Right.
cannot actually treat trauma. That's not our job.
Okay. I feel that trauma is in the tissues and it gets held in like for me, what I experience
Hmm.
is like
Hmm.
the to me, it feels like the pelvis has gone.
Okay. I wonder if we could reframe our language. I know exactly what you're saying, but I wonder if
Yeah.
we could reframe our language, because when we tell patients that the trauma is held in their tissue, it's like they have to fix their tissues before they can actually get better. Whereas what they need to do, so tension is a top-down process.
From the
So
brain down to the
tension,
body.
the tension,
Yeah.
tension is created. So
Yeah.
Tasha Stanton did some beautiful work, even in just tightness, right? So if we're looking
Yeah.
at sort of muscle tightness, so whether we want to call tension and tightness the same thing, but
Right.
what she showed in low back pain was that actually stiffness and tightness in the low back pain is actually produced by the brain, not produced by the tissues.
Hmm.
Just like pain is produced by the brain. And so she's got some nice research around that piece, and we can maybe put that in the show notes and
Yeah.
connect that a little bit, right?
Yes, please
But
do.
one of the things that we need to think about is that our language is really important. And so when we say to patients the trauma is held in their tissues, we pathologize the trauma and we pathologize their tissues. And that's one of the things that I'm working really hard at the end of my career, trying to get physios to understand, because that's where the pain science has taken us, right?
Yeah.
Once we can create safety in the central nervous system,
Mhm.
then the tissues no longer need to protect. So
Absolutely.
instead of really kind of working on releasing tissues and making tissues healthy again, let's make the central nervous system healthy again. And
Yeah.
when the central nervous system becomes healthy again, then the tissues just respond in kind.
Absolutely. Absolutely. That central nervous system is the, what is it? The on off switch really of tension, don't you think? I mean,
It's the conductor, right? It's the
conductor, that's a great
conductor of the
analogy.
orchestra, right? It's the conductor of the
Yes,
orchestra. And
yes.
unless the conductor is actually on board, and you're not going to get beautiful music from that orchestra, right? And so,
Yeah,
I really think as physios and as rehab professionals, we need to kind of reframe our language around
yeah, I
trigger
love that.
points and pelvic floor dysfunction and a lot of that terminology we use, because the message to patients is you're broken. Your
Right.
tissues are broken, your tissues are dysfunctional. And actually, what's happening is your central nervous system is protecting the most important part of your body
Yeah. Well, the
for
central,
survival, right?
yeah, exactly. It's trying to keep them alive. And what I really like to do is just honor the response in the body, whatever it
Hmm.
may be,
Hmm.
right?
Hmm.
Like
Beautiful,
your
beautiful.
body did this to keep you alive. Yay, let's celebrate
Right.
it.
Yeah, yeah. But then how do we create more safety in your nervous system rather than all these danger messages, right? That's what's happening. They've got dominant danger messages. And so that can also happen in labor and delivery, right? And how do we prepare a patient, a client, for creating more safety and reducing the danger inputs? And
Yeah.
it means ahead of time looking at some constructs that are highly connected to benefiting from pain education. So we've got level one evidence that pain education reduces catastrophization. There's that big word again. We've got
Yeah.
level one evidence that pain education reduces fear. And we've got level one evidence that pain education helps us to connect the dots in how trauma impacts our nervous system over the long haul and how we can change the sensitivity of our nervous system so we create more safety than danger.
Awesome. And so remind us again, Carolyn, those three, is it just the three categories of people that we could really benefit from that pain
Yeah.
education?
Yeah. Very clearly in my practice, I would say if someone has nociplastic pain, so now we're getting into a little bit more about, so the pain that is more a pain system problem, right? A central nervous system problem versus a tissue-based problem, which is nociceptive pain, right? And so we could argue in childbirth, there's a lot of nociception going on. There's a lot of danger inputs coming from the tissues. Nothing's being injured. It's just prepping, right? So just like a marathon. Um, However, I've lost my train of thought here,
Yeah.
Lynn.
Well,
Okay,
and
let's just,
so you keep thinking about that because I just want to make the comment to clarify for people that
yeah.
when the cervix is opening and the
Mm,
uterus is contracting and the uterus is working to get the baby into the pelvis,
hmm.
there is no tissue trauma or damage being done. However, it feels very painful for some
Hmm.
people. I find
Hmm.
it so fascinating. Just had someone in my clinic last week who said, yeah, I was contracting and I was at like a 5 centimeters dilated, and I didn't even know I was in labor.
Right,
Right. And
right,
then you
right,
have someone who's, only at a 1 and they're contracting and they're hitting the roof
right, right,
because
right,
it feels so intense for them.
right, right. We talked a moment ago about the definition of pain, right? Pain is a sensory and emotional experience that protects us from actual harm, like when we cut a finger and break a bone and,
Yeah.
or potential harm. So there's a lot of potential for harm, right? When we're dilating the cervix and sort of pushing the baby through. So that's part of it. But the other piece is that the last part of the definition says that it always feels like the body is being damaged. It always feels like there's a tissue injury, right?
Yeah.
And again, if we don't understand that piece, we can start to become quite distressed in labor, and that can start to wind up the fear, which then increases the pain, increases the tension, that whole piece. So we were talking, I got my train of thought back. We were talking about catastrophization, fear, and trauma, right? And those three pieces. And I would say that for a lot of physios who haven't spent a lot of time around the pain science piece, they'll sometimes say, well, I understand that this person that's presenting to me certainly has a pain system problem, so I'm going to teach them a bit about pain. But if their pain sensitivity is due to depression, which is highly comorbid with musculoskeletal pain conditions, right? Educating them about pain is not really going to change the depression, right? What changes the depression is actually an exercise program, right? Getting people to do cardiovascular exercise, weight training, yoga, those things change depression. So to think that we should kind of give everyone pain education just because they've got nociplastic pain doesn't fit. And I think that's where we've gotten into some trouble in the pain science movement, is that, well, if you have persistent pain, I'm going to teach you about the pain system. The people who benefit, according to the research, and Adrienne Lau's work has shown this, and some meta-analysis have shown this, is that people who are catastrophizing, people who are highly fearful, are ones who actually need to understand the pain system. And intuitively, we've both been practicing for a long time. We used to say things like hurt does not equal harm to patients, right? But they never believed us because it hurt. And so how could it not be harming the tissues, right? But now that we do have the pain science educational information at our fingertips, we can actually demonstrate to patients through good scientific information that pain does not equal harm, right? Or that hurt does not equal harm. And so I think it's really addressing that piece with the right patients, and then it makes a world of difference. People who are catastrophizing, who understand the pain system, no longer catastrophize. And now they're not sensitized by those catastrophic thoughts. And now their nervous system is more resilient, right? And now they've got more safety happening in their system. Now going into birth with this really intense experience, they're in a much better position to handle those intense signals that are coming from the tissues around stretch and contraction.
Yeah. And I know in my work that those pelvic floor muscles are our sense of safety and security in the world. Like if we're not feeling safe and secure, the pelvic floor muscles tighten up. And that's why I'm a big fan of not creating pain, trying to get those muscles to let go, because there's a reason you're tight, right? And finding that safety and security is huge, especially for childbirth. And helping someone to be able, because I'd be curious, Carolyn, because I feel like the pain, when we get that pain or what we perceive as painful, tighten up. So then it becomes more painful. So it's this,
it's the pain, fear, tension cycle, isn't it?
Yes.
Like we get pain, we become fearful, we get more tense, we get more pain, and it just kind of feeds into itself. So, where can you intersect with that? And that's where some skilled preparation, just like skilled preparation for your marathon.
Yes.
Right? Changes the outcome. Maybe would have had less pain had you actually prepped for the full versus the half, but you're like, I'm just going to do it. And you know what? Doing it didn't injure your body. You have great capacity in our systems are highly, what's the word I'm looking for? Highly robust, right? Like we are robust. Our tissues are strong. We have great capacity in our tissues. And one of the things as physios we need to be really careful of is that we don't create fragility in our patients. We don't create fear, and we don't make them more fragile by telling them some nonsensical terms around dysfunction, and this is wrong, and this is wrong, and this is in the wrong position, and this is right. And that piece does not fit with what we now know around pain science and kind of how the body works.
That's one thing that I'm really, really careful of, Carolyn, is when I'm assessing a pregnant person and they're coming to me for labor prep. I'm like, your body can do this.
Yes.
Your body can do this. And this position might be more optimal for you.
Mm-hmm.
you know, and
Mm-hmm.
not you should never lay on your back,
Mm-hmm.
or you should never
Mm-hmm.
do this, but this position will be more optimal for you. So if you feel it, I really try to help my clients feel what their body wants to do.
Right. Right.
You know, like
Nice. Yeah.
listening, birth is a dance between you and baby, your body and your
Mm-hmm.
baby. And
Mm-hmm.
so what does your body want to do
Right.
to help facilitate that release? Because it really is about a release and letting go and
Yeah.
opening up,
Yeah.
which we all know is a very challenging thing in our society. Is, you know, I think control is one of the biggest issues that we as women have, trying to control everything out there.
Right. Right.
And we can't control birth. We can't
Nope.
control the labor. And
No.
I don't know if you've experienced it, but in my practice, the women that come in and say, I only want this, this, and this to happen in my birth.
Right.
It's a setup for that to exactly not happen.
Mm-hmm.
Or I'm not going to learn about C-sections because
Yeah.
I am just not going to go there. Well,
Right. Right.
they end up
Yeah.
going there, you
Yeah.
know, and
Yeah. Yeah.
I try to work with my clients to really face their fears,
Mm-hmm.
so that we can diminish them. And I'd say the fears that are unaddressed are really the fears that end up coming up in their birth.
Right, right, yeah. So developing psychological flexibility, right? And developing a plan, but then also being flexible around, okay, if this happens, then what, right? Or if this happens, then what? And the more flexible we are, the more open we are to making changes and doing the dance that needs to happen, because
Right.
there are so many things outside of our control, aren't there? Yeah,
Yes,
yeah.
absolutely. Oh, Carolyn, this has been fabulous. Such a great
Awesome.
conversation. I love having this greater awareness of that pain science and really being able for us as practitioners to determine our clients who are catastrophizing. I said it
Hmm.
well.
You did. Good job.
And a lot of fear, and then the adverse childhood experiences. Those
Right.
clients, right? Those were the three big issues. If our clients are
Hmm.
dealing with those clients would best benefit from understanding more about pain science
Correct.
prior to
Correct.
going into labor, correct?
Absolutely.
Okay,
Absolutely. Yeah.
great. And so Carolyn and I were talking before we hit the record button. Carolyn's going to be joining us for the Birth Healing Summit this year too. And she was recommending that we invite in Ibi Alafabi. Did I say that correctly?
You
Yeah.
did. You
So
did. Yeah.
tell us more about IBI and what we're going to
Mm,
discover more in depth during our summit interview.
awesome. So Ibi Alafabi is a pelvic health physiotherapist. She's a mama of 5 beautiful children. She's a childbirth educator. She's a certified doula. So she comes from this really beautiful space of empowered birth. And she has done a really super job of integrating the concepts of pain science education into her childbirth education work. And again, looking at preparing women from that perspective, understanding a bit more about pain and the pain system. And although I've been in the pain field probably for the last 15 or 20 years, looking at pain science and using pain education in my practice, I would say Ibi is much more qualified to really talk about that piece as it relates to childbirth. So I suggested to Lynn that she come and join us and share her expertise. She teaches a course for us at Reframe Rehab, which she'll be teaching in May again. And it was a brilliant course. I just recently took it myself, and really learning how to apply the skills that I have in this sort of pain education world to childbirth has actually been a game changer for me. So
Wow,
I'm
awesome.
excited. Yeah.
Yeah, I can't wait to hear what we learned then. So
Right.
thank you, Carolyn. So we will put you talked about adding something to the show notes, so we'll make sure we get that link for everybody
Right.
in there.
Right.
And
Yeah.
was there anything else that we would want anybody to know about? We can put the link to Reframe Rehab in there, and maybe Ivi's courses and
Sure.
your
Sure.
courses as
Yeah.
well. So
Absolutely. That would be great. That would be
okay.
great.
Yeah.
We could maybe put a link to the childbirth, the fear of childbirth questionnaire, I think is the name of the questionnaire. So it's a brand new questionnaire that specifically looks at fear in childbirth. And I think that that would be a really great tool. I'm just starting to look at it myself in my own clinical practice. I think it was just published in 2022, so it's a very recent publication, but maybe looking at that piece as well would be an important piece. And Ibby can speak more to that and kind of the role of assessing fear avoidance and fear in childbirth and what does that mean?
Great. We're going to dive deeper into that in the summit interview. So we'll talk more about that questionnaire, but thank you for, we'll add it to the show notes so that everybody can have access to that. So start looking at that and we can dive in deeper to that in the next interview during the summit. Okay.
Awesome. Okay.
Carolyn, thank you so much for your time, for sharing your wisdom. I can feel your passion about pain science, and you really, truly did open my eyes to understanding the language and of how trauma is not held in the tissues. It's more a central nervous system response in the body, and how we need to help our clients kind of reframe that as well. So thank you for that. Appreciate that.
Thank you, Lynn. That was great.
Awesome.
Look forward to the summit.
Yes. All right. Thanks everybody for listening in, and we will see you all on the next episode. Take care. Bye-bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.